Very good morning to one and all. I am Dr. Shyamala, Senior Resident in the Department of Anesthesiology, SLIMS. Today we are going to discuss about pulse oximetry. Before going to the main topic, let us quickly discuss the basics first. We all know that we human beings require oxygen for our life. All the organs depends for requires oxygen for metabolisms, especially the brain and the heart are particularly sensitive to the lack of oxygen. Shortage of oxygen results in hypoxia. A serious shortage of oxygen, that is severe hypoxia, even for few minutes, is fatal. We all know that during anesthesia, the patient airway may become compromised, the airway may become obstructed, the breathings may be depressed, the circulation may be affected by blood clots or an abnormal rhythm, or any other anesthetic equipment may develop problems such as accidental disconnection or obstruction of the breathing system circuit. All this can result in the reduced delivery of oxygen to the patients, which if not managed properly, can lead to injury or death. So the anesthetic provider detects these problems early. The sooner these problems get treated, it is less harm to the patient. So coming to the oxygen transport, we all know that oxygen is carried around the body by iron containing protein called hemoglobin. Hemoglobin consists of globin chain, that is two alpha chain and two beta chains with the parfenin ring at the with central heme at the center. And hemoglobin can carry oxygen and when iron in the form of perovskite. That each hemoglobin can has the ability to carry about 4 oxygen molecules. We all know that heart normally comes about 5,000 ml of blood per minute to the tissues in an average size adult. And this delivers about 1,000 ml of oxygen to the tissue per minute. The cells in that is each hemoglobin has the each gram of hemoglobin combines with 1.3 ml 1.34 ml of oxygen. So in a normal average adult, considering normal hemoglobin is 15 gram per deciliter, around 100 ml of blood can carries about 20 ml of oxygen, which can be combined with hemoglobin. In addition, oxygen is also dissolved in the blood. So a cell can extract oxygen from the blood for metabolism is around 250 ml per minute. This means that even if there is no oxygen being exchanged in the lung tissues, and there is only enough oxygen to be stored in the blood is about only for 3 minutes. And this shows then oxyhemoglobin, that is oxygen binds with the ferrous form of the heme present in the hemoglobin. And this is the deoxyhemoglobin where there is no oxygen binding. The oxygen carrying capacity of the arterial blood can be calculated by 1.34, that is Huffner's constant, that is amount of oxygen in milliliters carried by each gram of hemoglobin multiplied by oxygen saturation of arterial blood multiplied by hemoglobin plus 0.0031 multiplied by partial pressure of oxygen. The relationship between the partial pressure of oxygen and then hemoglobin saturated with oxygen is best explained by the oxygen hemoglobin dissociation curve. It is then sigmoid shaped curve, and the binding of first oxygen molecules to the hemoglobin to deoxyhemoglobin the lower partial pressure is the lowest, which causes that curve to be flat here. So this binding of first oxygen molecule causes a conformational change in the hemoglobin molecules, which allows the binding of subsequent oxygen molecules to it, which causes a rise in the curve. And whenever the hemoglobin sites are occupied by 4 oxygen molecules, the curves levels off again, that is, it becomes plateau. So whenever the saturation lies between 90 to 100%, it corresponds to partial pressure of 60 to 70 millimeters of mercury or more. When the saturation level falls below 90%, the curves becomes more steeper. And hereafter, even a small drop in the oxygen saturations can lead to the significant drop in the partial pressure of oxygen, which is very dangerous for the patient. So efficient oxygen transport relies upon the ability of hemoglobin to reversibly load and unload the oxygen. P50 is the point at which the 50% of the hemoglobin is saturated with oxygen, which corresponds to the partial pressure of 26.6 millimeter of mercury. And this point is very important because with this we can say that whether there is the leftward shift or rightward shift of the curve. Whenever there is rightward shift of the curve, as seen in conditions like acidosis, hyperthermia, increasing 2,3 diphosphoglycerate level, there is unloading of oxygen to the tissues. That is delivery of oxygen to the tissues. So whenever there is the leftward shift as seen in conditions like alkalosis, hypothermia, or decreasing 2,3 DPG level, and there is uploading of oxygen from the tissues can occur. So as I said before, when the saturation lies between 90 to 100%, the partial pressure of oxygen lies between 60 to 70 millimeter of mercury or more. When the saturation falls below 90%, the curve becomes more steeper, and thereafter even a small drop in the oxygen saturation will lead to a significant drop in oxygen partial pressure. So before coming to monitoring, let us quickly revise what we have seen as of now. So oxygen transport depends upon the ability of hemoglobin to bind and unload the oxygen to the tissues and the tissues. We all know that hemoglobin has four globin chains, two alpha and two beta chains with a porphyrin ring at the center containing heme protein, that is iron protein. Hemoglobin can carry oxygen only when lying in the form of ferrous state. Each hemoglobin has the ability to carry four oxygen molecules, and each gram of hemoglobin will carries about 1.34 ml of oxygen. So in an average normal adult, 15 gram per deciliter, considering 15 gram per deciliter as the hemoglobin level, and each hemoglobin can carry up to 20 ml of oxygen attached with the hemoglobin. And a small amount of oxygen will also dissolve in the blood. So if without oxygen, the tissue can survive up to 3 minutes. So oxygen carrying capacity of the arterial blood can be calculated by 1.34 multiplied by oxygen saturation of arterial blood multiplied by hemoglobin plus 0.0031 multiplied by partial pressure of oxygen, which is about 41.1 millimeter of mercury. Coming to oxygen dissociation curve, it is a sigmoid shaped curve. The binding of first oxygen molecule to the deoxyhemoglobin is lower at the low partial pressure of oxygen levels, which causes the curve to be flat. As the binding of oxygen molecule causes a subsequent binding of oxygen molecule, since hemoglobin has an allosteric site, there is a subsequent rise in the curve form. Once the hemoglobin, all the sites of the hemoglobin is occupied by oxygen, the curve levels off again, which becomes plateau level. P50 is the point at which the 50% of the hemoglobin is saturated with oxygen. It corresponds to partial pressure of 26.6 millimeter of mercury. And it shows with this we can say that there is a left shift or right shift of the curve. Whenever there is the right shift of the curve, as seen in conditions like acidosis, hyperthermia, and increase in 2,3 diphosphoglycerate level, and there is unloading of oxygen to the tissues. There is delivery of oxygen to the tissues. Whenever there is a leftward shift of the curve, as seen in conditions like decrease in 2,3 diphosphoglycerate level, alkalosis, or hypothermia, there is uploading of oxygen from the tissues. With this basics, we can go for monitoring. Why monitoring is important? What is monitoring? First, monitor is a word come from the monitor, which means warning. So monitoring generally means to be aware of the state of the system, to observe a situation for any changes which occur over a period of time. And monitoring during anesthesia aids to know when to make a therapeutic intervention. It also to guide the assessment of those intervention. As I said before, various changes can occur during anesthesia, including airway obstruction, breathing depression, and cardiac circulation may be impaired during anesthesia. So we should monitor continuously for these changes to occur. For these changes, if happens, we should act promptly. Why monitoring is important means, as I said before, various disturbances can occur during the surgery, like airway obstruction, respiratory depression, and apnea, cardiac depression, arrhythmias, bradycardia, tachycardia, hypertension, hypotension, hypervolemia, hypovolemia, various fluid shifts, hypothermia and hyperthermia. So we have to monitor continuously these parameters. And if once disturbances occur, we have to act promptly and we have to detect early and treat it promptly. The primary goal of anesthesia is to keep the patient safe in the perioperative period, that is preoperative, intraoperative, and postoperative period. Continuous monitoring of the patient during and after anesthesia is must, which allows the early detection of problems and the correction of those problems. It can also even detect the equipment failure early. Harvey Cushing, he is the Harvey Cushing, who is a famous neurosurgeon who invented and popularized the anesthetic chart. He recorded both blood pressure and heart rate, and he emphasized the relationship between the blood pressure and heart rate along with the neurosurgical events. And he concluded that increased intracranial pressure can lead to hypertension and bradycardia. So coming to main topic, pulse oximetry. It is a non-invasive method of measuring hemoglobin saturation. It is also called as fifth vital sign. So it helps to detect hypoxemia even before the clinical signs of hypoxemia occurs, such as cyanosis, change in heart rate, or observed. Mathis, who is known as the father of oximetry, and Glenn Millikan is the one who first used the oxygen sensing monitor to monitor oxygen delivery and detect the unrecognized failure in artifacts. He is the one who coined the term oximeter. In addition to measuring oxygen saturation, pulse oximeters with additional wavelengths are also available now to measure the carboxy hemoglobin, hemoglobin, and other different proportions of hemoglobin present in the blood. Pulse oximetry measures capillary oxygen saturation in the blood using the principle of spectrophotometry. It follows Pierce-Lambert's law. And this picture shows the Pierce-Lambert's law. That is, Pierce law states that whenever the light is transmitted through the substance with the dissolved solute image, the concentration of the substance increases. If the concentration of the substance increases, the intensity of the light transmitted through it decreases. And Lambert's law states that whenever the light falls on the homogeneous substance, the intensity of transmitted light decreases as the length of the light path increases. So based on the principle of pulse oximetry, there are main two types of pulse oximetry: transmission pulse oximetry and reflectance pulse oximetry. A pulse oximeter estimates oxygen saturation from the differential absorption of red and infrared light in the blood at different wavelengths. Reduced hemoglobin absorbs more light in red band with wavelength of 660 nanometer, whereas oxyhemoglobin absorbs more light in the infrared band at a wavelength of 940 nanometer. This graph shows the absorption of light in different wavelengths, and this shows the reduced hemoglobin, which absorbs more in the red wavelength at a 660 nanometer, and this shows the oxygenated hemoglobin, which absorbed in the infrared band at wavelength of 950 nanometer. So the pulse oximeter computes the ratio between these two signals and relates the ratio to the arterial oxygen saturation by empirical algorithm. A pulse oximeter pulses red and infrared light emitting diodes over several hundred times per second, and thereby discriminating the arterial blood and other components by determining the change in the transmitted light caused by the arterial blood flow. If any other substances that absorb the light present in the blood, it causes the pulse oximeter calibration invalid. So these are the light emitting diodes present over the side, which can be detected in the light detector present on the opposite side. As I said before, there are two main principles. Based on the principle, there are two main types of pulse oximeters used: transmission pulse oximetry, which is most commonly used, and reflectance pulse oximetry. And this is the transmission type of pulse oximetry, in which the light emitting diode is present on one side and photodetector is present on the opposite side, and it depends upon the light transmitted through the vascular blood. Whereas in case of reflection type, the light emitting diodes and photodetectors are present on the same side adjacent to each other, and it relies on the light scattered back, that is reflected back from the substance. So this is the reflectance pulse oximeter probe in which the light source and the sensors are situated adjacent to each other. This is the reflectance pulse oximeter probe placed over the forehead with the handband securing it in place. As I said before, the intensity of light transmission occurs at two wavelengths, 660 nanometer and 940 nanometer, which is a reflection of deoxyhemoglobin and oxyhemoglobin respectively. Fractional oxygen saturation is calculated by oxyhemoglobin to the sum of all the hemoglobin present in the blood, which includes carboxy hemoglobin, net hemoglobin, fetal hemoglobin, subhemoglobin, everything. But in case of functional hemoglobin, which is calculated as a fraction of oximeter hemoglobin to the sum of oximeter hemoglobin and reduced hemoglobin. As I said before, normal oxygen saturation levels falls between 95 to 100%. So before going to the parts of the pulse oximeter, we quickly revise the types of pulse oximeter and the principles of pulse oximeter. Pulse oximeter follows the principle of spectrophotometry. It follows Beer's-Lambert's law. Beer's law states that when the light is transmitted through the substance with a solute dissolved in it, the intensity of transmitted light decreases as the concentration of the substance increases. Lambert's law states that if the light falls on the homogeneous substance, the intensity of the transmitted light decreases as the distance through the substance increases. And there are two types of pulse oximetry mainly commonly used based on the principles, which includes transmission pulse oximetry and the reflectance pulse oximetry. Out of this, transmission pulse oximetry is most commonly used, in which the light emitting diodes and the photodetectors are present on opposite to each other, and the light is transmitted through the vascular bed. Whereas in case of reflectance type, the light emitting diode and the photodetectors are present on the same side adjacent to each other, and it relies on the and it relies on the light reflected back from the surface. So coming to the parts of the pulse oximeter, it includes probes, cable, and console. Probe is the part which comes in contact with the patient. Cable is the one which connects the probe with the pulse oximeter. Console is the where the signal is processed and displayed the SpO2 reading on the monitor. So this is the finger probe which is connected to the finger. So coming to the probes, a probe is also called as sensor or transducer. It is the part that comes in contact with the patient. As I said before, it contains the one or more light emitting diodes that emit light at specific wavelengths and a photodetector. The probes can be reusable or disposable. Disposable probes are very easier to use, but they are less economical compared to the reusable probes. And probes are available at different sizes and shapes. And this picture shows the different finger probes of various types and shapes, various sizes. So if the probe is too large for the patient, some of the light passes can reach the photodetector without passing through the tissues. So it can produce falsely high SpO2 reading. And SpO2 reading is also affected by the extraneous light, which can be eliminated by covering the probe with an opaque material such as surgical towel, gauze, finger cord, blanket, alcohol white packet, or the other foil sheet. So these are the various types of pulse oximeter used. This is the desktop pulse oximeter. This is a finger probe, and this is the pulse oximeter attached with the monitor placed in the workstation. So this is the handheld probe. This is the disposable flexible probe. These are the reusable probes most commonly used on a finger or toe. In infants, these types of probe can be placed on the part of the hand or foot. And these probes offer good shielding from the ambient light. Sites where the probe can be applied include finger, toe, nose, earlobe, tongue, cheek, forehead, and esophagus. So this picture shows the probe placed over finger, nose, and earlobe. And this is the disposable nasal probe which hold in place. So finger, the pulse oximeter probe most commonly placed over one of the fingers, and this location offers a low failure rate with good accuracy. Even if there is poor circulation, finger block or digital pulse infiltration or vasodilator may improve the performance. Vigorous rubbing of the fingertip may temporarily improve the circulation in the area and thereby gives the accurate reading of the SpO2. Arm positions may also affect the reading. In most of the patients, the SpO2 may fall after the monitored arm is raised or lowered. In general, the arm opposite to the one in which the non-invasive blood pressure cuff is applied should be used. If it is placed on the same arm as the blood pressure cuff, the pulse oximeter will not give an alarm during the inflation cycle. Occasionally, poor function may occur with the probe attachment on the same extremity as the intravenous infusion because of the local hypothermia and vasoconstriction. Toe is an alternative site where the finger is not available or when the signal from the finger is unsatisfactory. It can detect the desaturation will not be as rapid as sensor on the toe as with more on the centrally placed probes. Nose is usually a convenient location. It can be used when it is a better site as compared to the probe placed over the extremities. It can respond more rapidly to changes in saturation as compared to the finger probes. The place where the finger probes placed over the nose include bridge, wings of the nostrils, and the nasal septum. It has been recommended under the conditions like whenever there is the poor perfusion of the peripheral tissues, when there is hypothermia, hypotension, or vasoconstrictor drug infusion. In hypothermic patients, the nasal septum is found to be more reliable site as compared to the finger. If the patient is placed in the triangular position, there will be a venous congestion of the nose, which causes the pulse oximeter to display artificially low saturations. Ear probe can particularly useful when there is a finger motion or when patient is having poor peripheral circulation or vasoconstrictive effect because ear is relatively immune to the sympathetic vasoconstrictive effects. The response time is faster as compared with the finger probe and it may also perform better as compared with finger probe whenever the perfusion is poor. And the main disadvantage for ear probe is it can give erroneous readings compared to finger probe when the patient is having tricuspid incompetence or in stiff head-on position. Reflectance type of pulse oximetry has been used on the superior surface of the tongue. It is especially useful in patients who have burns over the large percentage on their body surface. The tongue clearing may mimic the tachycardia. Other problems seen with the placement of probe over the tongue are venous congestion resulting from the head-down position and excessive oral secretions. Probes at the cheek detect the increases or decreases in saturation more quickly as compared to the finger or toe probes. Buccal oximetry is found to be effective during hypothermia, reduced cardiac output, increased vascular resistance, and other low pulse pressure states. The main disadvantage includes difficulty in placement of probe over the cheek, poor acceptance by the patient who are emerging from the anesthesia, and artifacts during airway maneuvers. Esophageal probes uses reflectance type of oximetries. It is better perfused as compared to the extremities during the poor peripheral perfusion stage, and it is better reliable for patients with hemodynamic instability. Reflectance type of pulse oximeters can also be placed over the forehead as I shown below with the help of headband, which is usually easily accessible and less affected by the vasoconstriction from the cold or poor perfusion. It should not be used if the patient is in triangular position. So this is the disposable wraparound probe on the foot. And these are the various, this is the ear probe and this is the flexi probe. As I said before, cable is used to connect the probe with the oximeter, and the probe cables cannot be interchangeably used, even though if the plug may fit into another manufacturer monitors. Console is where the signal is progged and the values are reported. The displayed values for SpO2 and the pulse rate are usually weighted averages for a certain duration. It allows the averaging period to be adjusted. Changes in the pulse rate and then oxygen saturation will be more rapid if the averaging time is shorter. And if there is much more probe motion, the averaging period could be adjusted longer. Most instruments provides an audible tone with variable pitch that changes with saturations, which allows the anesthetic provider or user to be made aware of the changes in oxygen saturation without looking at the oximeter. Before going to the users, let us quickly revise whatever we have seen till now. So, you all know that pulse oximeter use the principle of spectrophotometry, and it follows Beer's-Lambert's law. And there are light emitting. There are two types of pulse oximeter: transmission type and the reflection type. Light emitting diodes are present on opposite to each other in case of transmission type. In case of reflectance type, the light emitting diode and photodetectors are present on same side adjacent to each other and relies on the scattered light back. Coming to the sites where the probes can be applied, the most common site is finger followed by toe. The main disadvantage is it can be affected, the readings can be affected by poor peripheral circulation. But we can improve the readings by vigorous rubbing the fingertip by causing vasodilator and by covering the probe with like a foil sheet or alcoholic white gauze or cotton. So the other sides are nose, earlobe, tongue, cheek, esophagus, and forehead. And these sides are used whenever there is poor peripheral circulation and whenever there is hypothermia or vasoconstrictor drug infusion. Nose is better reliable for whenever the patient is having hypothermia. The main disadvantage for these sites are when patient is placed in steep Trendelenburg position or in head-on position, there will be a venous congestion of the nose and which gives them false low readings. So coming to the uses and interpretations, it limits the sequelae of hypoxemia before the clinical signs of hypoxemia can occur like tachycardia, altered mental status, cyanosis which may be masked or difficult to appreciate during anesthesia. The common problems associated with pulse oximeter is it does not ensure adequate oxygen delivery or utilization. It is a poor indicator for adequate ventilations, whoever on supplementary oxygens. It is inferior to the capnography in unrecognized brainstem and endobronchial intubations. Coming to the indications, it can be used to all the patient groups to detect and prevent an hypoxemia. It is simple, non-invasive, continuous, auto-calibrating, and quick response time. It can also be used for monitoring during transport. The accuracy rate is about 2 to 3% and 70 to 100% of oxygen saturation, and it is about 3% at 50 to 70 percentage of oxygen saturation. And this causes the reduction in the anesthesia mortality and fewer malpractice claims associated. It is particularly useful in patients with cardiac arrest, asthma, any type of chronic obstructive pulmonary disease, acute respiratory distress syndrome, endotracheal intubation, sleep apnea, or any other respiratory complaints. The other uses include providing feedback about the efficacy of breathing intervention and the therapies like use of ventilators, assessing whether the physical activity is safe in patients with respiratory and cardiovascular problems, continuous monitoring of patient oxygen saturation during stay space, monitoring of oxygen saturation over a period of time. It also helps in alerting the healthcare team to critically low oxygen levels, specifically in the newborns, in evaluating if the supplemental oxygen is necessary or not, keeping track of oxygen saturation in patients under general anesthesia. It is also indicating when any adverse event in individuals taking drugs that cause potentially breathing difficulty and low oxygen saturation like opioids. Coming to the summary of use of pulse oximeter, it can be used during anesthesia care, all types of anesthesia like during tracheal intubation, induction and emergence, one lung anesthesia, regional anesthesia, and monitored anesthesia care. It can also be used for monitoring in post anesthetic care unit. transport and post-op opioids. Monitor and also to monitor peripheral circulations, systolic blood pressure, and to avoid hyperoxemia. There is no clinical contraindications for using pulse oximetry. So depending upon the saturation levels, we can intervene the patient. If the saturation is more than or equal to 95%, there is no significant intervention needed. If the saturation falls between 88 to 92%, we can continue with respiratory assessment and monitoring. If the saturation falls between 85 to 94%, we call it as hypoxia, and you should assess for underlying respiratory diseases and should initiate the oxygen therapy, especially in the COPD patients. If the oxygen saturation level falls less than 85%, we should administer supplemental oxygen immediately to avoid the further damage. The advantages of pulse oximetry is it is accurate and the readings are not affected by the anesthetic vapors or gases. It has fast response time, especially compared with the transcutaneous measurements. It is the non-invasive, which allows it to be used as a routine monitor. And pulse oximeter is accurate in patients with distant arrhythmias provided the SpO2 is stable. The plethysmogram is noise-free and has a reasonable amplitude. Changes in the pulse rate tone with varying saturation level allow the user to be continuously updated without taking his or her eyes off the patient. The disadvantages of pulse oximetry probe are with failure to detect oxygen saturations. The failure rate increases in conditions like ASA physical status 3, 4, or 5, either elder or young patients, during orthopedic surgery, vascular surgery, electrosurgery use, and during cardiac surgeries. The failure rate also depends upon the presence of chronic renal failure in patients with a low hematocrit value and motion of the sensor site. It also depends upon the duration of the intraoperative procedures. And failure rate increases with patients with hypothermia, hypotension, and hypertension. The other disadvantage is poor function with poor peripheral perfusion, difficulty in detecting high oxygen partial pressures. It also difficulty in detecting the delayed hypoxic event. Conditions like venous obstruction, peripheral vasoconstriction, cold, and other motion artifacts can result in increased time to detect the hypoxemia. Erratic performance seen with dysrhythmias, inaccuracies and false alarms can occur, failure to detect the impaired circulations, and failure to detect the hypoventilation. So before going to inaccuracy of pulse oximeter reading, let us briefly revise whatever we have discussed till now. So we all know that pulse oximeter is of two types, transmission pulse oximetry and the reflectance type pulse oximetry. It follows the principle of spectrophotometry, and it follows Beer's-Lambert's law. Beer's law states that whenever the light is passed through the substance with a dissolved solute in it, the intensity of transmitter light decreases as the concentration of the substance increases. Lambert's law states that whenever the light falls on the homogeneous substance, the intensity of transmitter light decreases as the length of the light path increases. In case of transmission type pulse oximeter, the light emitting diodes are present on one side and photodetector is present on opposite side, and the light is transmitted through the vascular bed. Whereas in case of reflectance type, the light emitting diode and photodetector are present on the same side, adjacent to each other, and it relies upon the light scattered back from the substances. So the hemoglobin will observe in the different band, the different wavelengths, and this discrepancy between the SpO2 reading and between these two ratio, between these two signals is processed in the photodetector, and we can get the pulse oximeter has three parts, that is probe, consoles, and cable. Probe is the one which comes in contact with the patient. The probes of various types and the various sizes are available. For example, desktop probes, finger probe, handheld probe, disposable and reusable probes. Disposable probes are very easier to use, but it is less economical as compared to the reusable probes. Reusable probes can most commonly be placed over the foot or finger, and it gives accurate reading. It provides good shielding from the ambient light. The site most commonly used for probe application is finger, followed by toe, nose, earlobe, tongue, cheek, esophagus, and forehead. The main advantages for placing finger probe is it does not affected by the sleep hold-on position of the patient. The main disadvantage is it gives the erroneous reading when the patient is having hypothermia, or the patient is having poor peripheral circulation, or with the infusion of vasoconstrictor drugs. It can also be affected by placing the finger probe on the same side as the non-invasive blood pressure cuff. However, the pulse oximeter does not generate an alarm during the inflation cycle. So, toe is an alternative site for a finger probe whenever the finger probe provides an unsatisfactory readings, or whenever the fingers are not available. We can use toe as an alternative site for probe applications. It is also affected by the poor peripheral circulation and hypothermia. And these two disadvantages can be overcome by placing the probe over nose, earlobe, and forehead, and tongue, cheek, and esophagus. Nose, where we can place probe or the wings of the nostrils, nasal septum, and the nasal septum. Here, the main disadvantage of placing probe over the nose is it is affected by the tender end of position, that is head down position, which causes the venous congestion of nose, which results in the inaccurate readings of the pulse oximeter. So earlobe gives a better reading and gives better performance when compared to the finger probe or extremity probe, but it is also affected by when the patient is having tricuspid incompetence or when placed in the under in the position. Tongue and cheek are the reliable site for patients with hypothermia, but it is affected by patients who is having excessive oral secretions or patient who is in steep in the back position. Placing a probe over the main disadvantage of placing probe over the cheek is difficult in placement itself, and it is interrupted by airway maneuvers, and it is also affected. There will be a poor acceptance from of the patient whoever is emerging from the anesthesia. So esophagus and forehead, we have used the reflectance type of pulse oximeter, and it is affected by the steep trundle position. The esophagus probe can be used for patients with hemodynamic instability. So coming to the uses of the probes, we can use used for monitoring during anesthesia care, including all types of anesthesia like regional anesthesia, monitored anesthesia care, endotracheal intubation during induction as well as emergency, and during lung ventilation. It can also be used for monitoring in post anesthetic care unit, during for monitoring during transport, and for monitoring oxygen saturation in patients who are taking drugs that cause the difficulty and that cause decrease in breathing and low oxygen saturation, like patient use on opioids. It can also be used for avoiding hyperoxemia through monitored peripheral circulations and systolic blood pressure, etc. The main advantage is it is non-invasive, continuous, simple monitoring, and it gives accurate reading. The main disadvantage is erratic readings can be with dysrhythmias and failure to detect the oxygen saturation in conditions like ASA physical status 3, 4, or 5, whenever patient is having hypotension, hypothermia, chronic renal failure, low saturation levels, low hematocrit levels, and whenever there is increased duration of intraoperative procedures, there will be a chance of giving erroneous reading in pulse oximeter. Failure to detect high partial pressure of oxygens, failure to detect poor function with poor peripheral circulation will be seen. Um, so, failure to detect impaired circulations and failure to detect hypoventilation. Inaccuracy readings will be seen with the pulse oximeter whenever there is a different due to presence of different hemoglobin levels, severe anemia, severe hyperbilirubinemia due to pressure effect, and hyperemia. So we can see one by one. So different types of hemoglobins are present in the body, but most pulse oximeters used only two species of hemoglobin, that is reduced hemoglobin and oxygenated hemoglobin, but the blood contains other moieties also, which disturbs the wave-like absorbance ratio used to determine the oxygen saturation. Methemoglobinemia, normally the level falls less than 1% of total hemoglobin. It is an oxidation product of hemoglobin that forms a reversible complex with oxygen, which imparts the unloading of oxygen to the tissues. Methemoglobinemia can be a congenital or acquired one. Acquired methemoglobinemia can be caused by drugs like nitrobenzene, benzocaine, cetacane, and dapsone. Methemoglobin absorbs light equally at the red and infrared wavelengths, which are most commonly used by the most of the pulse oximeters. The discrepancy between SpO2 and the functional saturation increases as the level of the methemoglobin increases. If there are conflicting results between the pulse oximeter and the arterial blood gas analysis, we should suspect methemoglobinemia, and the diagnosis can be confirmed by multiple wavelength oximetry. The other type of hemoglobin present in the body is carboxy hemoglobin. It is formed when the hemoglobin is exposed to carbon monoxide. It has an absorption spectrum similar to the oxyhemoglobin. So most pulse oximeters will overrate the XPO2 by the percentage of carboxy hemoglobin present in the body. Although the most study shows that the fetal hemoglobin does not affect the accuracy of pulse oximetry, very high levels can lead to the slightly low oxygen saturation level reading. Hemoglobin as use of pulse oximetry in patients with sickle cell disease is controversial. Several investigators have concluded that pulse oximetry is very inaccurate in these patients, but other studies have found that pulse oximetry to be sufficiently accurate can be useful. Self-hemoglobinemia may be caused by drugs such as sulfonamides, dapsone, metoclopramide, and phenantazine. It causes the pulse oximeter to display artificially low oxygen saturation. The other conditions which affects the pulse oximeter reading is causing inaccurate readings include severe hyperbilirubinemia. Low oxygen saturations, like patients with a poor peripheral circulations or when patients with dark skin, the pulse oximetry becomes less accurate in these situations. So it should be used in caution with the cyanotic heart diseases. Measuring partial pressure of oxygen and or arterial oxygen saturation is more helpful in those conditions rather will they depend upon the pulse oximeter reading. Pulse oximeter technology assumes that pulsatile components of the light absorbance are due to the arterial bed, but patients with artificial ventilation, like those on ventilator, have high airway pressures, which may cause the basic venous congestions, which may be interpreted by the oximeter as the pulse wave. Thereby, it causes underestimating the SpO2. In some cases, it may be necessary to off the ventilator and to obtain the correct reading. Pulse oximeter overestimates the SpO2 in patients with severe anemia, especially at the low saturations. Skin pigmentations also influences the reading of the pulse oximeter, although some earlier studies shows that pulse oximeter readings were slightly high in patients with a dark skin. Newer studies have concluded that pigmentations does not make a significant difference with pulse oximeter accuracy. Placing a one manufacturer probe with a different manufacturer instruments provide the inaccuracy of the pulse oximeter reading. Nail polish and coverings also influences the accuracy of pulse oximeter reading. Like some shades of brown, black, blue, and green nail polish or onychomyosis, the condition which causes the yellowish gray discoloration of the nail caused by fungus may also cause significantly lower saturation readings. Synthetic nails or dirt under the nail may interfere with the pulse oximetry readings. Pressure on the probe also causes the inaccurate SpO2 readings without affecting the pulse rate determination. If the limb becomes hyperemic after the blood flow is interrupted, the oxygen saturation shown by the pulse oximetry may be artificially low. A pulse oximeter placed near the blood transfusion site may also influence the reading of the pulse oximeter, which may show transient decrease in the arterial oxygen saturation with rapid blood transfusion. Probe damage also causes the inaccuracy of pulse oximeter reading, which may be caused by cleaning agent, changing the cleaning agent not recommended by manufacturer on a reusable probe. A damaged pulse oximeter probe can cause the oxygen saturation to be higher than the actual value. Before going to the complications, let us revise once. Um, So you all know that oxygen is carried by hemoglobin. Hemoglobin consists of two alpha chains and two beta chains along with a parfenin ring at the center with heme in it. So hemoglobin binds with the oxygen only when the ion in the form of ferrous state. Each hemoglobin can carry up to 4 oxygen molecules. Each gram of hemoglobin carries 1.34 ml of oxygen. The oxygen carrying capacity of the arterial blood is calculated by 1.34, which is known as Hoffman's constant, that is amount of oxygen and milliliters carried by each gram of hemoglobin multiplied by arterial oxygen saturation multiplied by hemoglobin plus 0.0031 multiplied by partial pressure of oxygen. The relationship between partial pressure of oxygen and the saturated hemoglobin is best explained by oxygen hemoglobin dissociation curve. And oxygen dissociation curve is a sigma shaped curve, and the shape is due to when binding of a single oxygen molecule to the deoxyhemoglobin. The lower oxygen partial pressure is lowest, which causes the curve to be flat, and this causes the transfunctional change in the hemoglobin structure since it is an allosteric structure facilitates the binding of subsequent oxygen molecules so that the curve increases. Once the hemoglobin cells are occupied by the oxygen molecules, the curve will levels off again, which becomes plateau thereafter. The normal oxygen saturation lies between 90 to 100%, which corresponds to partial pressure of 60 to 70 millimeter of mercury or more. Even if the saturation falls less than 90%, even a small drop in the partial pressure of oxygen, drop in the oxygen saturation will lead to the significant drop in the partial pressure of oxygen. And P50 is the point at which the 50% of the hemoglobin is saturated with oxygen. It is very important as it determines the leftward and rightward shift of the curve. If there is rightward shift of the curve, as seen in conditions like acidosis, hypothermia, increasing T3 diphosphoglycerate level, and there will be an unloading of oxygen to the tissues, that is delivery of oxygen to the tissues. If there is a leftward shift of the curve, as seen in conditions like hypothermia, decreasing 2,3-diphosphoglycerate level, or alkalosis, there is uploading of oxygen from the tissues level. P50 corresponds to the partial pressure of oxygen of about 26.6 millimeters of mercury. So coming to pulse oximeter, it follows the principle of spectrophotometry. It follows Beer's-Lambert's law. Beer's law states that whenever the light falls through the substance, the concentration of the substance increases. Whenever the concentration of substance increases, the intensity of the transmitted light decreases. And Lambert's law states that whenever the light falls on the homogeneous substance, the intensity of the transmitted light decreases as the length of the light path increases. And based on the principal state, there are two types of pulse oximeters. One is transmission type pulse oximeter and reflectance type pulse oximetry. In case of transmission type pulse oximetry, the light emitting diodes are placed on one side and the photodetectors are present on opposite side, and the light is transmitted through the vascular bed. Whereas in case of reflectance type, the light emitting diodes and the photodetectors are present on the same side adjacent to each others, which depends upon the light reflected back from the substances. There are different types of probes available. There are three parts of pulse oximeter, which includes probe, cable, and console. And probe is the one which comes in contact with the patient. There are different size and different types of probes are available. The most common sites for applying probe are finger followed by toe, which is affected by the poor peripheral circulation, hypothermia, use of the laser constructed plug infusions, which could be overcome by placing probe over nose, earlobe, forehead, tongue, cheek, and esophagus. Esophagus is best for patients with hemodynamic instability. By placing probe over nose, tongue, cheek, and forehead, earlobe are affected by whenever the patient is placed in the cannula position, it gives the erroneous reading. Pulse width can also affected by the extraneous light, so it should be covered by using a blanket or gauze piece or alcoholic white cotton or foil sheet, etc. So uses of pulse oximeter, it can be applied to all the patient groups of all the ages. It can be used for monitoring during anesthesia care, which includes all type of anesthesias like tracheal intubation during induction or emergence, during one lung anesthesia, regional anesthesia, or monitored anesthesia care. It can also be used for monitoring in post-anesthetic care unit for monitoring during transport to avoid hyperoxemia, monitor peripheral circulation and systolic blood pressure. So the main advantages, it is simple, non-invasive, there will be a continuous monitoring, auto-calibrating and fast response time. And the disadvantages of probes are failure to detect the oxygen saturation, failure to poor function with poor circulation, failure to detect the high oxygen partial pressures, erratic performance will be seen with dysrhythmias, inaccuracy and false alarms can occur, failure to detect the hypoventilations. It is especially useful for patients with cardiac arrest, endotracheal intubations, and whoever having respiratory problems like asthma, COPD, sleep apnea, and patients who is on drugs which causes decrease in ventilation or breathing or causes low oxygen saturation like opioids. So with this revision, we can go for complications of using pulse oximeters. The most common complication while using pulse oximeter probe is pressure and ischemic injuries. And injuries can ranging from persistent numbness to ischemic injury at the site where the probe was placed. And this can be increased by increasing prolonged probe applications at the same site, compromised extremity perfusion, and tight probe application. So frequent site examination as well as moving the probe to different sites reduces the likelihood of injury. Burns are the rare complications seen with placing the pulse oximeter probe. Injuries ranging from reddened areas to third-degree burns under pulse oximeter probes. To avoid burn injuries, we have to frequently change the probe site from one site to another. So there is no clinical contraindications for using probes in patients. So with this, we can conclude the topic. So you should remember that what is monitoring, why we have to monitor, principles of pulse oximetry, types of pulse oximeter probes, where sites where we can apply, advantages, disadvantages, uses and interpretations, inaccuracy of the readings, and complications. The conditions where inaccuracy of pulse oximetry readings can occur include different types of hemoglobin, the increase in different proportions of hemoglobin, severe hyperbilirubinemia, severe anemia, whenever patient is having hyperemia, or whenever there is a patient is having nail polish or coverings over the nail. So different types of proportions of hemoglobin that causes inaccuracy of readings include a methemoglobinia, which is usually less than 1%. It is an oxidation product of hemoglobin which causes reduced delivery of oxygen to the tissues. And they can be acquired or congenital. The most common cause for acquired hemoglobinemia is drug induced, and drugs which causes hemoglobinemia include um, um, drugs which causes methemoglobinemia include then the other conditions include a carboxy hemoglobin, where when the hemoglobin is exposed to the carbon monoxide, it is formed and it causes it absorbs the absorption spectrum is almost similar to the oxyhemoglobin, which causes the false readings. Severe anemia will give overestimates the SpO2 level at the low oxygen saturation levels. Whenever the lump is hyperemic, it gives the false reading. So whenever the patient is having a when the probe is placed near the blood transfusion site, there will be a false readings. Severe hyperbilirubinemia can lead to increase in the methemoglobin and carboxy hemoglobin, thereby it causes inaccurate readings. Nail polish, especially the shades of brown, black, green, and blue color, will cause the inaccurate readings. And the conditions like onychomycosis causes yellowish gray discoloration of the skin, which causes erroneous reading. Then dirt under the nail and will also affect the readings of pulse oximeter. It should be cautioned in patients with cyanotic congenital heart disease, and patients with dark skin will have the inaccuracy of readings. So coming to the complications, we know that there are two complications mainly. One is ischemic injury or pressure effect. It ranges from mild numbness to the ischemic injury at the site on which the probe is applied. It is especially seen in patients whenever the probe is applied for prolonged duration and whenever there is the tight application of probe to the patient. So we should frequently monitor the site and we should change the probe from one side to another side frequently. Burns is very rare and it ranges from rental areas to third-degree burns. Uh, to avoid the burns, frequent probe site inspection as well as the site rotation is recommended.